So the talk is sort of the use of ARV7. What I'm going to sort of do is use that as a launching pad to talk really about the potential other predictive markers that could be used clinically, and sort of orient all of you about the direction in which we need to be moving and taking as we get more and more patients with all these new therapies. As people develop resistance to many of these therapies. So these are my disclosures. So we know that prostate cancer was really observed as an endocrine-driven disease by the sentinel work of Huggins and Hodges back in the 40s, and as you know, they were the only urologists to win the Nobel Prize posthumously in the 60s. So we've known forever that if you take out testosterone, you will have basically apoptosis and death of prostate cancer cells. So really all that is driven, and I think this is for those of us that deal with this disease, and as a trained urologist, if you would have told me 15 years ago that I had to understand at the molecular level the androgen receptor and everything that it does, you know, I would have told you, no way, I'm a surgeon, I don't need to know that. But I think as we move forward and what we know now is that it is very critical to understand the androgen receptor. So like any talk, there's always a few slides that are worth something and the rest of them aren't worth much, but this is a slide that I think everybody needs to have a basic understanding. So this is sort of the canonical pathway of how testosterone and the androgen receptor work at the cellular level. So we know that testosterone basically is circulating, and it comes in basically a free and a bound form. Most of it is bound by sex hormone binding globulin, but once it dissociates from its binding globulin, you have basically movement of testosterone basically by diffusion. It's not actively transported, it diffuses into the cytoplasm of the prostate cell. Then, as many of you know, testosterone gets converted to its more potent form via an enzyme called 5-alpha reductase, which sits in the cytoplasm of the prostate cell, into dihydrotestosterone. Dihydrotestosterone then binds to the androgen receptor, and what happens is that the androgen receptor in the cytoplasm actually has these chaperone molecules. These chaperone molecules dissociates when you get ligand nearby. You get binding of the ligand to the androgen receptor. You get dimerization. You then get translocation of the androgen receptor ligand complex into the nucleus of the prostate cell. Then within the nucleus, it basically binds to DNA. You have all these coactivators, and then this is basically you go from transcription here. So you basically get transcription, mRNA, and then you get translation, and out pops PSA, which again is a protein that is a function of androgen binding and a number of other factors. So this is how testosterone results in PSA and cell growth. It's very important to understand this. Now, at the gene level, the androgen receptor is actually encoded on the X chromosome. And it has and so when you look at the androgen receptor gene, it has all these domains that are really critically important. So you have what we call the N-terminus here. This is involved in transcription. It has really nothing to do with androgen binding. You have a ligand binding domain on the opposite end, which is basically encoded for by these introns. You have a DNA binding domain, which is responsible for the receptor binding to DNA, which is also part of transcription. And then you have this hinge region. So you have 4 distinct areas, and you say, why is he really talking about this? How important is this, really? And it becomes very important because, again, there are about 300 proteins that touch the androgen receptor, and they all do different things. And what tends to happen, as David was talking about, this concept of metastatic castration-resistant prostate cancer, we have our patients all the time. This is like, okay, do I need to stay on these shots? Because pretty clear, the leuprolides and all these drugs that we're using to drive down testosterone is not working anymore. So doc, why do I need to stay on these shots? Because again, due to the heterogeneity of prostate cancer, we know that there are going to be clones that are still responding to low testosterone. However, what happens is that you get other resistance mechanisms, but it's still being driven by the androgen receptor. And I think that's a very important concept for people to understand. So again, this is a little bit of an older slide, but these are all the drugs that David mentioned in the mCRPC space. Actually, due to the PREVAIL trial, enzalutamide was approved in 2014 in the post-chemotherapy space, but really not much has gone on in the M1 disease state in terms of new drugs. But again, there's going to be much more coming out. So this slide basically looks at a lot of the different trials that are, again, we're starting to look at treatment, looking at agents really earlier than mCRPC. David's going to give you a talk on M0 CRPC, but you have a number of trials looking at basically these de novo hormone-sensitive metastatic patients that are showing up, and obviously the patients that progress beyond definitive therapy. So these next few slides are really not meant to be exhaustive, but it basically goes to show you a lot of the work that's been done. Many of you are familiar with the CHARTED trial. So this was reported out by Chris Sweeney. This is, again, basically patients that present with metastatic disease who basically are hormone naive. And really what they did is that they basically randomized patients to get ADT plus ADT, either ADT alone or ADT of 6 cycles of docetaxel. And what they found is that the patients that received ADT plus 6 cycles of docetaxel basically had a did better with the combination than ADT alone. In terms of median overall survival, basically ADT plus docetaxel was 49.2 months, ADT alone was 32 months. And this was basically with people how they defined as high volume disease. And I think that's a concept that we're going to probably need to use more and more clinically. High volume disease in CHARTED was greater than 4 bony lesions, one of which was outside the axial skeleton, and or nodal disease and or visceral disease. In low volume disease, less than 4 bone lesions, there basically was not an advantage of ADT plus docetaxel versus ADT alone. So again, that becomes critical as you see patients who show up into your office with metastatic disease. You really should be sort of delineating whether they have high volume or low volume disease. Then we had the Latitude trial that basically was looking at abiraterone in the same patient population. Again, David's going to talk about these M0 trials, which is the use of enzalutamide and apalutamide in M0 patients. So again, these are CRPC patients. This is a different subgroup. And I think it's very important when we talk about advanced disease, we be very consistent of what patient population we're talking about. Are we talking about patients who have never been on hormonal therapy versus these patients that are CRPC? And again, the definition of CRPC is patients with prostate cancer on androgen deprivation therapy, testosterone's less than, hopefully, 20, but a rising PSA. That's the working clinical definition of CRPC. You have to differentiate those people from patients who present with metastatic disease who have never been exposed to LHRH therapy. Those patients, different drugs, different studies, but it's important to understand where these drugs are being used. So again, this was PROSPER, this was the use of enzalutamide, then there was Spartan, that's the use of apalutamide, basically in that M0 space. And again, I'm going through these because what's happening is that we're using these agents earlier and earlier. All right, we're exposing patients to these drugs earlier and earlier. And so why is that important? It's because of this slide here, is that whenever we start to use drugs earlier, then these cancer cells, they're smart. They are smart, and they will undergo mutational changes. So once they get to this CRPC, and I will contend that as we start to use these drugs earlier in the course of the disease, the M0 patients where they have no demonstration of metastatic disease, that patient, when they do progress to M1, is going to be very different at a molecular level than the current M1 patients that we're seeing now, which is going to be very challenging. And that's the basis of this talk, is we have to understand, once they start to mutate, what testing can we then do to help us define therapy. Because again, we don't really have any markers that are guiding us. When to use Xofigo, when to use abiraterone, when to use enzalutamide, when to use Sapulus LT. All those drugs are out there. We're sort of using our clinical judgment. We're throwing it against the wall and hopefully that it sticks. There's nothing driving how we're utilizing these drugs. But just understand is that once you start to use these drugs, you will get these resistance mechanisms. And some of them are androgen receptor dependent, but you do have some AR independent mechanisms. All right, so it's important to understand where these resistance mechanisms and why they developed. So again, this slide is actually very good because it's really giving us all the potential pathways, ligand dependent. And we're going to talk about a few of these briefly. It's not going to be an exhaustive trial. I'm just trying to let you know, sort of expose you to what are the things that we need to be looking at. What are some of the labs doing? What are some of the companies doing? So we have AR amplification. You get this PI3 kinase pathway with all these coactivators. You get tissue steroidogenesis. There's all these pathways that actually will cause these cells to escape androgen suppression and continue to grow. So again, the potential heterogeneity-induced mechanisms of resistance include genetic alterations to drug targets, expression of multi-drug resistant pumps, and again, you have this evasion of apoptosis. So the one thing that's gotten a lot of attention, and this is why I went through with you very closely the androgen receptor, are what we call these AR splice variants. And again, the one that we know is commercially available, you can order, is ARV7, but just understand is that, again, when you look at the like anything that it can affect this intron, all these domains can result in a variant. But again, the one that we commonly talk about is what we call this ARV7 splice variant. This is the most abundant AR splice variant. And what happens is that it's called the V7 splice variant because the ligand binding domain, which is basically coded for by regions 4 through 7, the ligand binding domain in this splice variant drops out. It drops out. So you have a androgen receptor variant that doesn't possess the ligand binding domain. So again, like we talked about, you would think that would be good, right? It can't bind androgen. It can't bind, you would think, based upon the canonical pathway, that would be a good thing. The problem is that despite the dropout of the ligand binding domain, this receptor stays constitutively active. So despite having a dropout of the ligand binding domain, the receptor stays active. And so what it then does, it gives you it will lead you then to say, okay, then using, in theory, the use of any androgen axis modulator, whether it be an androgen receptor synthesis inhibitor or an androgen receptor blocker, really may not work because, again, that's still modulating the AR axis. So many of you are aware of this study. This was reported by Emmanuel Antonarakis at Johns Hopkins. And this was a small study, 31 patients with MCRPC that were eligible for abiraterone and enzalutamide. And what they did was that they identified through a proprietary assay at Johns Hopkins using circulating tumor cells, they tried to identify whether or not these patients had the ARV7. So again, when you looked at the abiraterone arm and the enzalutamide arm, basically the baseline ARV7 status was about 19%, 39%. You know, we know that so this was actually with treatment. Look down here, the treatment status, the prevalence is about 12% before either drug. But then what happens is that as you get on treatment, the incidence of the ARV7 increases. So once they become ARV7 positive, then if you look at this abiraterone arm, if they're ARV7 positive, their ability to drop PSA to PSA 50 was 0. If they're ARV7 negative, you still had a fairly response to drug. And the PSA 50 is 68%. And it's very consistent looking at RPFS as well as overall survival, as well as that pattern held true in the enzalutamide arm. So again, if you're ARV7 positive, these drugs are not going to work because, again, it's not affecting, they're not binding the androgen. This is just a different way of looking at it. When you look at PSA progression in the enzalutamide arm, basically if you are ARV7 positive, you had a limited effect. If you are V7 negative, it obviously, you know, you had the effect. Same way with the abiraterone arm. And again, this is clinical RPFS, clinical or RPFS. It's the same pattern. And these are just waterfall plots showing you the same thing. So again, this led to this commercial development of the assay, which is, again, looking at trying to test using circulating tumor cells, looking for the ARV7, which is a nuclear expression. It's expressed within the nucleus. Let me finish this real quick and then we'll take questions, okay? But again, there's other mutations out there. And again, I'm not going to go through these exhaustively. You have a gain of function mutation in DHT synthesis. So what this means is that the cells, as opposed to taking androgen or testosterone to convert to DHT, they will take other steroids and convert to DHT. So they don't need testosterone. They'll actually take another ligand, and with this mutation, they will still produce dihydrotestosterone. You get a glucocorticoid receptor activation, which again is AR independent, which can also basically have increased expression in patients with MCRPC. You can have these microsatellite instabilities, and these will become more important. PIK3. See, this was reported on at PCF is this inactivation of CDK12, and actually when this happens in about 7% of CRPC patients, and if you measure this might lend you to actually use some of the immunotherapies that Dan's going to talk about. This is a very good paper. This is the Robinson paper looking at integrative clinical genomics, and again, what we know is that about 23% of metastatic CRPC patients harbor DNA repair alterations. But what we also know, and this is the Pritchard paper, is that about 12% in men who die of prostate cancer, not just CRPC, that who die of prostate cancer, harbor germline alterations in DNA repair genes. So these are germline mutations. These are hereditable. So again, this concept of what we talked about, taking a more detailed history, family history, this becomes very important. And these patients died, and this was irrespective of family history or race. Irrespective of family history or race. So we talk a lot about BRCA and BRCA1, BRCA2, and a new generation of drugs that will probably be approved, which are PARP inhibitors. So I'm going to fly through this pretty quickly, but again, what happens is that cancer cells survive, they survive these breaks, and there's multiple repairs that cells use to survive. So what BRCA does, BRCA helps identify DNA damage, and then PARP comes in and basically starts the repair. So in a normal cell, if this is a cancer cell, and if there's a single-stranded break, what happens is that PARP comes in, you get excision, you get repair, and the cells survive. Now, if you have a BRCA biallelic loss, so it's got to be a homozygous loss in the repair, then what happens is that they cannot, when you add this PARP inhibitor, and I'm happy to share this article with you, when you add this PARP inhibitor and you have a BRCA deficient cell, it's this dual lethality, it results in cell death. If you only have a monoallelic loss, then the cells still survive. So that is the importance when patients progress, especially as we may get these PARP inhibitors that potentially are going to be approved. We should, in order to use these, more than likely, you're going to have to test for BRCA1, BRCA2, and all these DNA repair genes. So again, Lenny Gamella and his team at Jefferson sponsored this prostate cancer consensus conference looking at genetic testing. This is a very good article in the role of hereditary testing. This was presented at PCF, and these are all the targets people are looking at. These are the multiple different pathways of resistance. So we know that, yes, we can test for ARV7, that is commercially available, but again, what's going to happen is that we need to be developing all these predictive biomarkers to help us navigate these multiple drugs. So AR continues to be the major driver in growth and survival of prostate cancer cells, even in the CRPC patients. As urologists, we need to understand the nuances of resistance mechanisms and genomic alterations. As patients continue to progress clinically in the CRPC space, there is a critical need to develop predictive and prognostic biomarkers to help us optimize therapeutic choices in the world of precision medicine. And I'm 2 minutes over, so I apologize.